Coming up next on Primary Care, I talked to Dr. Don Misra about the impact of racism on infant mortality.
Have you experienced racism, and have you seen racism experienced by others across your lifetime, and perhaps that creates a chronic stressor for women?
Hello and welcome to Primary Care. I'm your host, Dr. Lonnie Joe. Did you know that black babies are more than twice as likely as white babies to die before the age of 1? Exactly why remains a mystery. Studies have shown that poverty, education, access to prenatal care, smoking, and even low birth rate do not explain this racial gap. Even black women with advanced college degrees are more likely to lose a child in its first year than are white women who did not finish high school. Some researchers, like my guest today, believe racism is a major contributor. Dr. Don Misra is professor and associate chair for research in the Department of Family Medicine and Public Health Sciences at the Wayne State University School of Medicine. Her research focuses on the extent to which racism affects infant mortality rates among African American women. Dr. Misra, welcome to the show.
Thank you.
How did racism come to the forefront of your research, and why do black babies die at higher rates than white babies?
Well, some of the statistics you talked about when I was getting a master's degree in maternal and child health and working with faculty who were working on this topic area, and I started hearing about this. And because at first I thought, I think what a lot of people think, it must be the poverty, it must be the high rates of lower education, maybe lack of prenatal care.
The usual suspects.
Usual suspects, and and it took people a while to do the research to try to say, was it that? And then these gaps were still there. And there were, so I started thinking about the college-educated women a lot, and as we'll talk a little bit later, racism is a multidimensional issue. There's a lot of ways to think about it, and we've measured lots of them in our work. But my first thinking around this topic was really around the issue of interpersonal racism. So I thought about these college-educated black women and thought, well, they're probably in workplaces where they might be the minority. And they might be going to places where there's still a lot of discrimination that they might experience, and people who think of them as being different. And I also thought about where they might be living, because in the US, this country remains extremely segregated. The Detroit metro area is one of the most segregated areas, as was the Baltimore, Maryland area where I did my first work. And there is, even for black women, they tend to live in areas that are highly segregated and actually much worse off in terms of both income, crime, and other neighborhood resources and factors than white poor women. And a lot of that's the legacy of segregation and redlining that's been present in the cities in the US.
So if you had to define racism in the context of your work, what would it sound like?
So we look at it in a couple different ways. So the first one I'll start with is where we started here is interpersonal. So we ask women questions. There's been a number of scales we've used, but one of them is really what now people talk a lot about is microaggressors. So sort of little things that happen to you. So you walk into a store, and does the clerk follow you across the room? Does somebody, and this happens a little bit more for black men perhaps than black women, but does somebody cross the street when they see you coming? So small things like that. Do you think you're getting service is different when you're in a store? So these are what we consider sort of daily microaggressors, and where that might add up and have an accumulation of stress. We also look, though, at lifetime experiences. So some of my early work, I thought about, is it really about what you bring to what's going on during this pregnancy, or is it about your whole lifetime? And have you experienced racism, and have you seen racism experienced by others across your lifetime, and perhaps that creates a chronic stressor for women. And we have tried to parse that out a little bit more recently. We have a paper that's out for review right now where we looked at what we call personal versus vicarious or other group racism. So if you ask black women or black men about the experience of racism, some of them will say, well, I think it happens, but not to me. And so we have these scales and questions that we'll ask about, did you ever experience this? Did this ever happen to you? But then we also have questions that say, did anyone in your family ever say this happened to them? Did anyone of your friends ever say this happened to them? And we found that they look like they're slightly different kinds of factors. It's not really the same thing to have it happen to you than to happen to your family, but also folks might be more wanting to, in a way of coping, to deny it happening personally, but understand when you look at the U.S., or you look at your city and you think about how blacks are treated, you might admit that yes, in fact, we're not treated the same. So we started delving into that a little bit more, and it does seem that there's impact also of when you experience race as your group rather than your own experiences of it. And finally, we get to sort of what we could call institutional racism, and we've tried to capture that a little bit by looking at neighborhoods. We know that there is this sort of residential segregation of where folks live. We also know that there's discrimination in terms of getting loans in the workplace, getting equal income in the workplace, the state of our schools being determined by where we live, which again goes back to where sort of the income is and where segregation happens. So that kind of aspect of racism we also probe about, mostly by asking women about where they live. We asked people for street addresses of where they live. And in our most recent study, I had thought a lot about intergenerational effects, and that maybe, again, it's not just where you're living now, it's about where you were born and what kind of environment did you grow up in. And so we've asked women to tell us about what the address was of where they were born, where they lived when they were 10, where they lived when they were 18. And something we really enjoyed doing, we got the mothers of the mothers in our last study to give us the answers to the same questions. So we could make sure that we were getting the right answers.
So that's that's drilling down on the social determinants of health.
Pretty detailed in our work on racism.
So everybody has a story. How did you get into this area of research?
So when I was, I grew up actually out in Brighton. It's a very small town, but my parents were native Detroiters. And so I, from an early age, paid a lot of attention to what was going on in Detroit. And when I went to college, I took a course in violence in contemporary society and learned about the unrest in the 60s in Detroit and LA and various places. And I started thinking about that as possibly a factor in health. But then I took a medical sociology course taught by actually most recently the chairperson who's now here at Wayne State, Janet Henkin. And she talked about infant mortality and how infant mortality is really tells you a lot about how a society takes care of its most vulnerable group. And if you look at countries that have high infant mortality rates, it will tell you something about that country. And it's also the primary determinant of life expectancy. So I got interested in this idea of infant mortality, and I started volunteering for the WIC program, which is Women's, Infants, and Children's Nutrition Program in Baltimore. Got a little bit of interest in that, and then went on for this master's degree and started hearing, as I said, about a little bit about these disparities and kind of thinking, well, what is this all about? And had luck to have some really great mentors along the way. And so by the time I was finishing my PhD, I worked in Harlem briefly, and there was a study there called the Harlem Birthright Study. And the study was actually about infant mortality in Harlem, but it was a community-based participatory research study. So the idea was not to go in and tell the community, okay, we want to work on infant mortality and what do you think are the problems. It was rather to say to the women in the community, what do you think is going on in your community? What do you think are the important issues? And it was done as a diary study in part, an ethnographic research around it. And so I was fortunate to be a research assistant at the time and read some of what the women wrote. And I started getting struck by their experiences with housing court, their experiences with the criminal justice system and their families, and how it seemed like they were having a lot of stress experienced from these things that I wasn't reading any papers that were actually measuring.
There was no references to those kind of data.
No, I didn't see much of that at all. And in fact, the early research, so preterm birth, which is the leading cause of infant death for all children, but also for Black children, that research had started growing into looking at stress. And so there were researchers saying, let's look at stress. But it was around white women who were well off and still had a preterm birth. And they thought, well, what could be wrong? Maybe it's stress. So they looked at the acute measures of stress and what was happening during your pregnancy. But they didn't look at chronic stress that we thought Black women might be more likely to experience, which might include racism and might include some of the chronic stressors of poverty. And they didn't look at things that might be more salient to Black women, which chiefly racism. So there were no questions about whether you were discriminated against or whether you felt stress from being a Black woman in the U.S.
So what's on the short list then, with all that you've said and that background, what's on the short list
of things I think matter?
Why African American babies die first, sooner, worse? I mean, what type of disease states, including the stressors, what kind of disease states are on that list?
So in terms of diseases, in the immediate, I guess, cause, you're going to the immediate cause of the death, preterm birth is the biggest contributor. So that is babies being born before what we say is 37 completed weeks of pregnancy, so more than 3 weeks before your due date. Being born small, even if you're not born early, is also a problem. So those babies, black babies, are more likely to be born small, even if they're not born early. But then we also have, these things are not mutually exclusive. So you have black babies that are born smaller than they should be for when they're born, and they're born early. So they have sort of two strikes against them. And those things affect death in the first month of life, but they also affect death later. So sudden infant death syndrome is the third leading cause of death in the infant period. More of the cause as you get later and later in infancy. And that cause is also increased risk for African American babies. And people don't think about it a lot, but that actually, the risk of SIDS is higher in preterm babies. So it's not just getting out of the first couple months of life, if you survive the NICU, that you're going to be in the clear. We have continued issues, and then safety is probably the final one, so accidents and injuries. So
surviving the trauma of all those instances actually gives us these numbers that nobody's proud of.
Yeah.
Doctor, we're going to go to a break. We'll be right back with Dr. Don Misra when we return.
Can you imagine the impact we can all have if we stand together for hope? Can you imagine the impact if we all renewed our commitment to continue fighting for a healthier start and a brighter future for every baby, today and tomorrow? Right now, when we work together, we can turn hurt to hope, sorrow to celebration. We can make a difference for so many families from NICU to now. We have a chance right now to take another major step towards this future, and we need your help. Through the end of this year, we are raising money for community, advocacy, research, education, and support. And if you make your gift right now or anytime between now and the end of the year, it could be matched dollar for dollar, doubling the impact of your generosity. Imagine the impact we could all have if we stand together. Imagine the difference your gift can make right now.
Welcome back. Dr. Misra, we don't want to presume that our audience understands these terms, prenatal, postnatal care stuff. Would you just give us a few definitions here of what we're talking about?
Sure. So when we're talking about prenatal, we're talking about any time from conception until the birth of the child. Preterm is pretty much synonymous with premature, although some people will use premature a little looser. Sometimes people think if their baby's a week early that they're premature, but any time after the 37 completed weeks of pregnancy is considered a term pregnancy. So preterm is everything before that, and so is premature. Low birth weight, you'll often hear referred to, is less than 2,500 grams or less than 5.5 pounds. And sometimes we talk about growth restriction, about small for gestational age or fetal growth restriction, and that's when the baby's not growing as well as it should. So if you have a 5.5 pound baby, what we call a low birth weight baby at term, that baby by definition is small for its gestational age. But you can also have a baby that's born at 33 weeks, quite early, but is a good size for being 33 weeks and not being growth restricted. Whereas you can also have a baby that's small at that point in time. It's smaller than it should have been even for being that early.
Comment on the story of the short birth canal, African American women, yes,
this has been an interesting story for me, and I think it illustrates the difference between perhaps clinical medicine and public health. So a while back, there were some studies looking at treating women who'd had a prior premature birth. So if you'd already had a premature birth, giving them progesterone starting very early in pregnancy to try to prevent that next preterm birth. And the studies were quite successful in showing a very big reduction in the risk of these future preterm births. And the focus became on whether this was because those women had a shortened cervix, that their cervix was short at the beginning of pregnancy and staying short when it should have been longer starting at the beginning of pregnancy. and thinking that the progesterone would sort of treat and address this. And so some studies were begun showing that, and some of it was done at the Perinatology Research Branch at the NIH, showing that if mothers had a short cervix and were treated this way with progesterone beginning early in pregnancy, they would have a greatly reduced risk of a preterm birth. And so it's a success story by sort of the clinical treatment standards, where it seems like we found a bit of a silver bullet to fix this problem. The issue in terms of, you think about public health and our whole population, is in fact very few women have a short cervix. And it's not clear that African American women are more likely indeed to have that short cervix than white women are. I think the research on that is still ongoing. But even if I were to be able to get all of the women with a short cervix into prenatal care very early, screened with ultrasound, get the treatment, it would impact the preterm birth rate and the infant mortality rate just a bit. It's this concept of what we actually talk about in public health of attributable risk. Something can have a really big impact, but if the exposure doesn't affect a lot of people, you can't have very much of an effect on your outcome.
So what role does genetics play in this whole discussion?
So I did actually ask, I mentioned to you before, my husband is a pediatric geneticist, and I study genetics only peripherally in my work, and I always kind of thought, well, what would I say about genetics? And I forget sometimes that to a layperson, when you think about genetics, you think about families. And yes, indeed, if you look at preterm birth, you'll see that it does cluster somewhat in families. And we mentioned recurrence. Sometimes women will have more than one preterm birth, which leads sometimes people in the public to think, aha, it must be genetic because you're having it in families. But families share a lot more than their genes. So often families share environment, and they share the environment across generations. And so, as you might know from other, people might know about other issues about health disparities, the genetic code between blacks and whites isn't very different. And so it would be very surprising if all of these health differences arose from these small differences in the code. But what I think might make a difference is what we talk about as genetics and environment interacting. Some people think about that, we call it context. And so if you think about it, your genes and my genes might be maybe just a little bit different, but our environments might be very different. And so my genes in that environment, I might have a problem, and my genes in another environment, I might be just fine. And so, as you know, genes are something that's pretty difficult to change. And so as we think about this issue, we tend to focus more on the environment or context and what we can do about that. But as yet there is very little that's been found that really seems to explain much of the disparity in this area.
Dr. Mercer, tell us about this expanded role that fathers seem to be playing in this whole business of birth weight and all of the issues around it.
So just as we, myself and colleagues started thinking about it going beyond education and the things we were looking at before, most of the research in pregnancy and on infant mortality had really focused just on the mother. So almost all the intervention studies were always done about mom, to the exclusion of anyone else involved in the family. And as you know, families aren't really just a mother. They expand beyond that. And so a colleague of mine at the University of Michigan, Cleo Caldwell, and I started talking together about maybe there being a role for fathers. And she had been doing a lot of work with fathers and sons, with teenage boys and their fathers, when that boy's significant other became pregnant, and trying to work on sort of family dynamics and different issues. And we discussed the fact that there was very little work really about the role of fathers. And fathers could have a role in a number of ways. There's certainly a biologic role, and exposures to the father that might affect the sperm, and again, might affect genetics, and different mutations could have an impact. And then there's a lot of social research focusing on the idea of support. So whether fathers are bringing money into the household, whether they're bringing social support in, that having an impact. But we really wanted to go beyond that and think about the father's health himself, his mental health, and how that might affect their relationship with the mother, and whether the relationship itself might have an impact on the birth outcomes. And that relationship might be a vehicle for improving birth outcomes. Rather than just focusing on what we can do for the mother, what can we do with this family that might help both of them and then might help to achieve a healthy birth. So a lot of research has been done on child development, of getting the father more involved in thinking about this, but not much on the prenatal period. So we started exploring what we could do about that. And we did a small pilot study. We're hoping to start a larger study in the next year or two to try to see what are the father's experiences of pregnancy. So we actually interviewed them separately. We interviewed the father of the baby and the mother of the baby separately, and a couple times during pregnancy, to look at things like depression symptoms, and also how the father might either be a barrier or a support of mother's own healthy behaviors. Some really interesting work in Washington, D.C. done with what we call focus groups, where they went and talked to people at length, and gave their stories. And the fathers talked about the importance of making sure mom got to prenatal care, making sure mom ate well, and making sure that she wasn't smoking and sort of having healthy habits. And we thought about that as also a potential role. And then there's the flip side. Unfortunately, sometimes fathers have negative health behaviors. And we know from research that when a father smokes, the mother's also, besides being exposed to the smoke, might be more likely to continue smoking herself. And so having a whole healthy family unit might be key in terms of improving our birth outcomes, not just improving the mother's health.
Whole lot of dynamics around that. But talk a little bit about how racism affects the life course of the father in terms of the infant's health.
So we haven't, as we've done very little on fathers, we certainly have done very little on life course with fathers. But we do know from the research we've done on mothers that her health when she was born, her own birth weight and her own health and the socioeconomic environment in which she was born, the income of her family, and how well off she was, has an impact above and beyond where she ends up later. And there's been some really interesting research recently out of Chicago looking at the fathers and linking the birth certificate. So taking the baby's birth certificate and linking it back to dad's own birth certificate and mom's own birth certificate, and finding out that dads who grew up in poor neighborhoods and grew up in neighborhoods that were highly segregated seem to have a child that has worse birth outcomes than the dads who did better. And so that even if the father and mother were better off now, if things had started then. And so racism in that sense, I think about as being sort of that institutional level, affecting neighborhoods and things like that. But we also know racism affects father's income just like it does mother's income. And perhaps his ability to be involved might be affected by those forces.
Can't let you get out of here without talking about the Fathers Matters study.
Yes. So that was our pilot that we tried. So we did it actually a little bit in Ypsilanti and a little bit actually in this very building that we're sitting in today, actually at Providence in their prenatal clinic. We recruited moms and asked them to identify the fathers of the baby. And we did pretty extensive interviews with them about their experiences of racism, their experiences of depression symptoms, their own early life experiences in terms of where they lived and how well off they were in childhood, and satisfaction with their jobs. And we've tried to relate some of those in the relationship between father and mother. And we are seeing pretty high rates of depressive symptoms among what we'll call them the expectant fathers, whether or not they've had a prior child. And we think, the depressive symptoms might be underreported and underappreciated in the African American community, particularly for males.
It wouldn't be fair not to mention the usual suspects again that add to this infant mortality problem, diabetes, hypertension, the social aspect of the thing, smoking, drinking, drug abuse. Those things are still at the forefront of changing behavior in terms of outcomes.
Yeah, I think the chronic diseases definitely make a bigger dent than people appreciate because we look at each individual disease, and so any one of those, they're frequent, but you think, well, how frequent could they be in women of childbearing age? But there was a study some years ago that looked, if you just look at the top four, hypertension, diabetes, asthma, and I think they added thyroid conditions, 1 out of every 4 Black women of childbearing age had one of those diseases.
25%.
25%. So when you add it up like that, even if each one of those diseases isn't that frequent, you can imagine it making a pretty big contribution. And those diseases don't get treated and cured in pregnancy. That's something from, again, childhood, adolescence onward. The drug abuse is sort of an interesting question. While certainly I would not suggest that it's an okay thing in pregnancy. I started off my work in graduate school thinking it was during the time when we talked about there being a cocaine epidemic, an epidemic of cocaine-addicted babies. And much of that was debunked later as really being a primary issue for Black and other minority babies in cities. Yes, it's not a good thing, and yes, it does lead to worse outcomes in terms of both the immediate birth outcomes and later developmental outcomes. But when we controlled for cigarette smoking, turned out that a lot of the effects are probably due to the cigarette smoking. And it also turns out that actually African American women who are in younger childbearing age actually don't smoke as much as white women. And so these sort of substance use issues, same thing with drinking. We actually find much lower rates generally of using alcohol among black women in the childbearing population than we do among white women in other groups. So none of those activities and behaviors are good for babies, but they probably don't explain a lot of the difference because they're simply not as frequent exposures for this community. So sometimes though we have tended to focus a lot on them because they seem very dramatic, and I think people get scared and think, well, what are people doing? And it's a little bit of that, what I would guess I could think about is blaming the mother. You know, it's what she's doing, it's not about other things. So yes, continue to hopefully reduce smoking and reduce the risks of these risky behaviors, but don't expect it's the answer.
Don, what's coming down the pike? What can we expect from this type of research in the future? What are your hopes?
So my hope is that we're going to continue working on measuring things, which is important to understand the problem better. But I do feel a drive to start seeing what can we be doing about it. And so that comes in a couple different places. One is making sure policymakers understand what we're talking about. And you know, there are of course things, you know, women should be getting prenatal care. They should be taking care of themselves. They should be managing any chronic illnesses they have. But we need society to do a better job caring for women and for their families. And so I'm hoping that as policymakers become more aware of some of this work, that they realize there's pretty hard work to do on the ground about changing the environment for black families in this country. And the other area probably is, I've done a lot of my work with communities, but not as directly with communities. And so I think you learn a lot from talking to the people that this problem affects. And so we're hoping in our next phase of work to do a better job with that, of bringing back moms to talk to us more about what kinds of things are we missing? Are there things that we're not studying that we should be? And what are the barriers to things changing? What do they see as some of the problems that we may not have actually been measuring well enough?
Exciting. Good. Thank you so much for joining us on the show today. We'll do this again for sure.
Thank you.
Good. My guest has been Dr. Don Misra, Associate Chair of Research and Professor in the Department of Family Medicine and Public Health Sciences at Wayne State University School of Medicine. Thank you for joining us today, and we'll see you next time on Primary Care. You can get more information about the show and our guests at primarycare-tv.com and continue the conversation on Facebook and Twitter.